Bueno, buenos días a todos ustedes. Que, les hablaré en inglés porque me lo han pedido, pero thank you so much for inviting me to speak on biomarkers in Parkinson's disease. It's really, anything you do with patients now is called a biomarker. We didn't used to call it biomarkers, but now anything you do, an X-ray or a physical examination is a biomarker. So I'm going to speak about biomarkers. It's a very clinical talk, unlike the previous talks. But I'm a clinical neurologist. So really, my talk is centered on the prodromal phase or the pre-diagnostic phase of Parkinson's disease. And I'm sure you all are well aware of what I'm talking about. This is a diagram that pretends to show you that before the symptoms of Parkinson's disease start and gradually progress, there is a premotor phase or prodromal phase during which the motor symptoms have not developed, but most likely the disease has already developed, okay? So we are interested in this phase because we think probably if we had a good treatment, we could apply it in the prodromal phase and avoid the major symptoms of the disease to develop. Now, just good. A little terminology. Prodromal means to that phase before the onset of motor symptoms where the patients already have some other kind of symptoms. For example, I don't know, fatigue or depression or loss of smell. This will be the prodromal phase, okay? But of course, the prodromal phase, the disease has clearly already started. The patient has already symptoms. There is a premotor or pre-diagnostic phase, which starts much earlier, in which the disease has started, but no symptoms have occurred, okay? So it's not the same to talk about prodromal or pre-diagnostic or premotor. Although most of my talk is about prodromal Parkinson's disease, okay? But I just wanted to clarify that to you. Now, for a number of studies, the chairman has asked me to cut down a few minutes, so I'll try to go quickly over this. But from a number of studies, we know that some prodromal symptoms in Parkinson's disease are loss of smell, sleep problems, especially REM behavior disorder. The patients have nightmares and agitation at night and can fall out of bed. Dysautonomia, mostly constipation, but also erectile dysfunction and bladder trouble, and maybe depression as well. But those are symptoms we know can occur in some patients. We don't know in how many, but before the onset of motor symptoms. So it's interesting to study these patients. Now, if somebody has constipation in the general population, maybe this is the prodromal symptom of Parkinson's disease, but if this is the case, half of the population in Spain would probably have prodromic Parkinson's disease. It's a very non-specific symptom, okay? Depression, of course, is, you know, after Barça could not win Atlético de Madrid, you know, half of Catalonia now is prodromal Parkinson's disease. So the issue is that we are dealing to very non-specific symptoms, and it's very difficult to diagnose prodromic Parkinson's disease. So because of this difficulty, because these symptoms are very non-specific, we have, I'll skip that because of the time you asked me to cut down, okay? We are trying to study prodromal Parkinson's disease in populations that are at high risk to develop Parkinson's disease. There are some of them that are very interesting. For example, people that go to sleep units and have REM behavior disorder, this sleep disturbance I'll tell you about, they are likely to develop with time Parkinson's disease. Patients with primary hyposmia, they are not so well studied, but it's a very important risk factor. And certainly asymptomatic mutation carriers. You know, if you have a LRRK2 mutation, you are likely to develop with time Parkinson's disease. It's an autosomal dominant form of genetic Parkinson's disease. Now, I will tell you about some data that we have accumulated or studied in patients with idiopathic REM behavior disorder and in LRRK2 mutation carriers. Now, in case somebody in this audience doesn't know, REM behavior disorder refers to a condition where the subjects at night have unpleasant dreams. Now, this fellow is saying, you know, he wants to kill his wife because he's dreaming of a crocodile. And they can, fall out of bed. They have to protect the bed. This is, it lasts for several minutes. And this is what REM behavior disease is in a capsule. But what's interesting is that if you follow patients with RBD, we'll call it RBD, with time, at 5 years, 33% have developed Parkinsonism. At 10 years, 76%, and at 15 years, almost all of them. So it's a high-risk population to develop Lewy body pathology. We know that from histological studies we've done in our brain bank by us and other people. Now, so this is one population. Now, the other population is LARC2 disease. It's the most common cause of genetic Parkinson disease. And as I put here, LARC2 asymptomatic carriers of the G2019S mutation have a more than a 20-fold increase in disease risk. So you follow this asymptomatic cohort, and they are likely to develop Parkinson disease when they get old, okay? So it's at least you are looking at subjects at high risk, not somebody with constipation in the general population. So there are interesting populations to study. Briefly, there is another interesting reason we want to study these patients, because as you've heard in the last talks and yesterday, we have synuclein immunotherapy, which we could apply to patients with RBD, because they represent prodromal Parkinson disease. And there are LARC2 kinase inhibitors being quickly developed by the Fox and sponsored by the Fox Foundation. I'll tell you the story some other time. But there's a lot of money behind that, and we think trials are going to start very soon in LARC2 patients and in asymptom. We would like to apply them to the premotor phase of LARC2 disease, okay? So this is a strong incentive to why we want to study this population of subjects. Now, as you know, in Parkinson's disease, the diagnosis is made by the presence of Lewy pathology, okay? We find Lewy bodies in Parkinson's disease and in what Dr. Yeo called dementia with Lewy bodies, which is Parkinson's disease with dementia, of course, but we find Lewy bodies in the Nigra cells and Lewy neurites in the brain. And we showed, and others as well, that you can find them in the peripheral nervous system. So this is the hallmark of diagnosis of Parkinson's disease. Now, if we could find this pathology in RBD, for example, or in LARC2 non-manifesting carriers, we would certainly know that they have ongoing disease, no? So what we did, there is a number of studies that have been done in Parkinson's disease with peripheral tissues, accessible tissues, looking at synuclein aggregates, and those are all the tissues that have been looked upon in stomach, colon, skin, and found variable amounts of synuclein aggregates. So we decided to look in the submandibular gland, of Parkinson's disease patients, because Charles Adler and others have already found a high proportion of patients that have pathological synuclein aggregates in Parkinson's disease. So very briefly, we had already looked in the colon before, but the interesting study is that we studied it in 21 patients with idiopathic RBD, in patients with Parkinson's disease and controls, and without this complicated study, it had to be radiologists, ENT surgeons, the brain bank helped us, so it was a complicated study, frankly, to do, but we succeeded, and by doing biopsies, we demonstrated that in the patients with Parkinson's disease, 67% of them had pathological aggregates of synuclein, which you would expect that, the majority of do, but also idiopathic RBD, almost 90%. So we really showed that idiopathic RBD is truly, we showed histological evidence that RBD is a synucleinopathy, is a Lewy body disorder. There is no question in our mind about that, okay? And, sorry, but here you can see in a biopsy of patient with Parkinson's disease, you can see the synuclein aggregates, which you never see in control subjects, and the same is true in the peripheral nerve in idiopathic RBD patients. Now, just briefly to tell you that in this population of idiopathic RBD patients, RBD, the sleep disorders, no Parkinsonism, okay, not only do they have synuclein aggregates that we can demonstrate histologically in vivo, but we've done, for example, olfactory studies in these patients. This is a study we did in collaboration with Innsbruck, And we found that those patients with idiopathic RBD that had smell scores, abnormal smell scores compared with the control, they would develop, most of them, after a 5-year follow-up, develop synucleinopathy like Parkinson's disease with or without dementia. So really, this was like a marker for short-term conversion to the motor symptoms of Parkinson's disease. The same we've done under the leadership of Alex Iranzo in Barcelona. We've done dopamine transporter specs in these patients with what we think is prodromal Parkinson's disease. And among those that had an abnormal dopamine transporter scan or sonography of the substantia nigra, compared with those that had normal substantia nigra imaging, after 2.5 years follow-up, 8 had developed Parkinson's, none those that had normal imaging. So abnormal nigral imaging, like with dopamine transporter spec, again, is a marker of a short-term phenoconversion in this population of patients. And actually, you can look at that spec and follow, with the passage of time, the progressive loss of uptake of the striatal ligand, okay? So we do have a marker of disease progression in premotor Parkinson's disease, which is that spec. Here you can see in the upper part, or just stick to the lower part, this is a patient that at baseline had a slightly abnormal dopamine transporter scan, but after 1.5 years or 3 years, there is progressive decline of the uptake of the DAT spec. So we have a marker of disease progression in this population of patients. So really, I think we are ready for trials, disease modification trials in patients with idiopathic RBD. It's an homogeneous, high-risk population. We have diagnostic markers like synuclein in the submandibular gland. We have predictive markers of short-term phenoconversion, like dopamine transporter scan, or olfactory abnormalities, and we have markers, as I showed you, of disease progression. Actually, there is a phase 1 study is already being devised with the support of the important Compañía Farmacéutica, so I think we are very excited about these studies in idiopathic RBD. Now, just to show you, I couldn't resist to show you, we are doing a study with Aarhus in Copenhagen, sending patients with RBD, and are doing a study of microglia activation with PET. And look at what we found. We are sending this paper hopefully this week, but we found, we found that patients with idiopathic RBD compared with controls have an abnormal fluorodopa PET, which you would expect that was known, but they have an increased inflammatory marker, PK1195 PET, of microglia activation in the substantia nigra. So really this suggests that microglial inhibitors could possibly play a role and could be tested in these populations of patients. Now, just a few words, because we have no time, about LRRK2 Parkinson's disease, which we have been studying intensively, and it's really a true challenge, a very difficult task because LRRK2 is the most exciting drug target identified in modern Parkinson's disease research. I quote here West, but I fully believe it's true. If we are going to cure one type of Parkinson's disease soon, it will be LRRK2 Parkinson's disease, because there is a lot of excitement, a lot of money, many people involved with that, or maybe I'm just hoping, okay, but I'm an optimist on that. Anyway, the question is, patients that carriers of the mutation, this is a patient that came to see us, and of course he comes every 6 months and we do spinal taps, biopsies. I mean, these poor fellows, they are so generous with everything. But this guy, you said, put this stick, still asymptomatic. Can we predict when will he develop Parkinson's disease? This is the crucial thing. We need to know diagnostic markers in these populations and disease progression markers. If not, we will not be able to do a clinical trial with these kinase inhibitors or other strategies we may have. So this is the big challenge. Now, we did a study using the International LRRK2 Cohort Consortium, comparing asymptomatic relatives that were mutation carriers comparing with those that were non-mutation carriers, hoping we would be able to separate them. Well, really, truly a bit disappointing, there were similar non-motor features. That is to say, olfactory scores and RBD scores were the same in the asymptomatic mutation carriers and the non-carriers. So they don't have a clinical prodrome, unlike RBD patients that could separate. So it is a bit of a problem, okay? We did find, though, that they have a lower dopamine SPECT uptake, like Dr. Shapira showed you yesterday for the GBI asymptomatic cohort he's following. So at least in that sense, they're in a way similar. Now, we also looked at CSF levels of a number of Alzheimer-type markers, beta, tau, phosphotau-synuclein, and because of lack of time, just believe me, we found what we expected, which was that synuclein levels in the CSF were decreased in idiopathic Parkinson disease, but not in LRRK2 disease. And we could not separate, which is what we wanted, the asymptomatic carriers versus non-carriers. Okay, this is the whole question. We couldn't. Still working in the spinal fluid of this tissue, we've done, Ramon Trullas has done, and his colleagues with our collaboration. An interesting observation is that mitochondrial DNA in the spinal fluid of LRRK2 Parkinson disease patient is different from idiopathic Parkinson disease. So this is, we believe, a very interesting and possibly potentially important observation, suggesting that there are biochemical different pathways to neurodegeneration in patients with LRRK2 compared with idiopathic Parkinson disease. But again, we could not separate non-manifesting non-carriers from the non-manifesting carriers. Okay, so we don't have a marker of the asymptomatic carriers of disease development or progression. So it's very, very challenging and very difficult, this population. Just finally to tell you kind of a conclusion, no? I told you about the prodrome of RBD-related Parkinson disease. Now, how about LRRK2 or G2019S LRRK2-related Parkinson disease? Maybe they don't have a clinical prodrome. That's the difference. My message to you is that this prodromic phase may be very different for RBD type PD or for LRRK2 PD or maybe synuclein-related, the other forms of genetic Parkinson disease. So the clinical phase is silent. They don't have RBD, hyposmia, depression. At least we could not detect that. We detected some imaging abnormalities like I put down here, reduced DAT-SPECT and sonography in the substantia nigra. Actually, what we did here is duplicate what the people in Santander had done, Sierra and Infante. So that's interesting. Those are imaging markers, but no clinical markers that we could find in this type. So I think to conclude, I think that this pre-diagnostic phase of Parkinson disease has many phases probably. Actually, it may vary a lot from one patient to another. But certainly, we get the feeling from our studies that's not the same to study RBD and how it progresses to Parkinson disease, or you study asymptomatic mutations carrier of LRRK2 disease, which are clinically very silent. So it's going to be difficult to do a trial in these patients. How do we diagnose ongoing disease? And, you know, anyway, we are working on it. And it may be that typical idiopathic Parkinson disease has a somehow different prodrome as well as the other genetic types. No? That needs to be determined. Of course, there are a lot of ongoing biomarker studies. I just mentioned 3 here. The so-called PARS study, which is a large cohort of asymptomatic hyposmic patients, how they develop Parkinson disease. The PPMI, Parkinson disease progression marker of the Fox Foundation, has a prodromic and a genetic arm. We are part of that study. So I think we will eventually get sufficient data on these asymptomatic genetic forms. The PREDICT study is in the general population. There are a number of studies that are truly interested in progressing in this sense. Now, that's all I have to tell you. I also would like to acknowledge the work of many people here in our hospital. Certainly, in the movement disorder unit, the fellows that did most of the work I published were Klaus Trepon and Dolores Vilas, and the tissue bank, brain bank, Ellen Gelpi has been mentioned before. She's been very important. But mostly Alex Iranzo in the sleep unit, he has been the driver of the idiopathic RBD population. And I'm very thankful to him for his interest and trust in me also. And finally acknowledge a number of collaborations that have been very important to develop these projects on prodromic or premotor Parkinson disease, collaboration with Innsbruck, with the Fox Foundation, and of course we have received funding from CIBERNED, and I have to acknowledge the collaboration of patients and many asymptomatic individuals. We have this large cohort of patients that come every 6 months to have spinal taps, DAT scan, nuclear magnetic resonance, fluor beta PET. Really, they've been extraordinarily generous with us. So thank you very much for your attention.
Thank you, Eduardo. We have time for a quick question. Dr. López Barmeo.
The fiber that you see synuclein in the fibers in the salivary gland, are they sympathetic fiber?
Yes, there are Th-positive fibers.
Th-positive fibers, yeah. Okay.
They are nervous tissue, Th-positive.
And do you have any indication that sensory fiber in the peripheral nervous system, and do they also have alpha-synuclein deposit? Do you have any evidence of that?
No, I have no.
Because some people talk to me related to using the cornea, the innervation of the cornea, that is very highly densely innervated, and they have preliminary data suggesting that fibers in the cornea, which are mainly sensitive fiber, also present early signs of alpha-synuclein deposits. Okay.
It's very interesting. Of course, there are many tissues peripheral that we maybe even better than the submandibular gland, because it's not very nice to have a biopsy of the submandibular gland. It's tolerable, but not very nice. We are looking at skin in collaboration with Dr. Navarro in the Autonomous of Barcelona, and hopefully skin will be easier. It's very easy to obtain and almost painless. But the results are not as clear-cut so far as it has been in the submandibular gland. But I agree, we have to be open. We recently did, by chance, we had the testicular tissue of a patient with Parkinson's disease that had an orchiectomy for cancer. It's full of synuclein. So some people may suggest you can do testicular biopsies in men. Again, not very nice, but full of major amounts of synuclein. So, I mean, in Parkinson's disease, unlike in Alzheimer's disease, we have a peripheral marker. We just have to learn how to best use it. Maybe we can do PET, a peripheral PET. People are thinking and trying to develop that will detect synuclein in the gut. Or, of course, let me just say, if we had a PET, a synuclein PET for the brain, like they have the Alzheimer doctors or researchers, they have an amyloid PET, that will be a major advance, incredibly major advance.
Thank you, Eduardo.